I'm waiting on you, right, Adam?
No, go.
We're go? Okay. Hi, this is Grover Norquist with Americans for Tax Reform. We have three experts with us to talk about what's happening to fight the virus by removing some of the regulations and rules and laws at the federal level, state level, and even the local level that have gotten in the way of fighting the virus. At Americans for Tax Reform, at our website, her.org/rules, RULES, we've come up with 500 different regulations, rules, and laws that have been either repealed or suspended because they got in the way of trying to get health care to people, trying to get hospitals and respirators to people, trying to get doctors and nurses to people or people to them as rapidly as possible. So there's been some things that should have happened maybe 5 years ago or 10 years ago or 50 years ago in terms of making medicine more accessible in urban areas, in rural areas, in areas of low-income people. All of these opportunities that could have been met, but maybe now will be because people recognize and are focused on healthcare in a way that they weren't. We're joined by Kopanos with the nurse practitioners, looking at various opportunities to expand medical care there. Nick Schilligo, who works with telemedicine, getting people eye exams over computers, and Latoya Thomas, who works on Doctors Without Borders, or without state borders. I've worked with Doctors Without Borders overseas, but this is an exciting one, getting past state border restrictions. And if I could ask Tay to start, give us a sense of what is a nurse practitioner, what do you do, and what gets in the way of you providing more and better care at more reasonable cost to more people that is or isn't moving right now?
Thank you. Thank you for the invitation today. Nurse practitioners are healthcare providers who diagnose, treat, manage, and prescribe for patients. The majority of nurse practitioners are in primary care, and currently the nurse practitioner workforce is about 250,000, actually a little more than that, so 250,000 healthcare providers. Nurse practitioners are providing care in every setting. Most of the time it's in primary care offices, but they're in hospitals, clinics, tribal healthcare centers, nursing homes, school-based health centers. And we're finding a majority of Americans have encountered a nurse practitioner for either their own care or for the care of a family member. Nurse practitioners are licensed in every state. And so I think our viewers will be most familiar with licensure laws for like their driver's license. You get a driver's license in your state that gives you the legal permission to drive. The same is true when it comes to licensure laws for your profession. Nurse practitioners are given state permission to practice. Currently, 28 states, DC, and 2 U.S. territories authorize nurse practitioners to provide all those services that I listed directly to patients. In the remaining 28 states and 2 other territories, NPs are required by law to have a contract with a physician, a permission slip, if you will, getting additional permission from a physician to be able to provide those services to patients, like prescribe a prescription medication or diagnose a patient. Those really create delays. If you don't have a permission slip, even though your education qualifies you to provide those care, you can't provide it. And so the NPs have been practicing for over 50 years, and we're really finding that in states that require that permission slip for a clinician to practice their profession or a patient to provide services, it's really causing bog down, delay, and slowdown. We've known that for a while, and COVID has helped highlight the need to move on reform.
Okay, excellent. Thank you very, very much. So it's almost 50-50, but it's 28 do it right or too restrictive, which is the number that are doing it closer to making it more available to people?
22 DC and 2 territories. So 22 do it right.
Okay, and 28 could increase access to medical care if they were to adopt the rules that 22 have.
Absolutely. Follow the model language.
It's always helpful to be able to tell a state legislator this is done in 20 other states plus, because then he knows the world hasn't ended, and worse than that, nobody's lost an election over the subject. And it's therefore safe. We have with us Nick Schilligo with 1-800 contacts. Can you talk about telemedicine in your zone? What is the restriction that some states have that others don't? And how many states let people get this done, and how many stand in the way?
Yeah, thanks, Rover. So, at 1-800-CONTACTS, we're the largest contact lens seller in the world. As you could probably tell from our name, we've been disrupting the contact lens marketplace since before the tech boom. We've been around for almost 25 years, and we have continued this disruption recently over the last 4 years by offering a telemedicine tool that is called Express Exam. So this tool allows a patient and a provider to meet virtually through an asynchronous relationship, so store and forward technology. Our platform captures clinical data from the patient who answers a medical history relating to their eyes, and then also goes through a series of vision tests if they qualify. That information is then forwarded to an ophthalmologist, board-certified ophthalmologist that's licensed in the state of the patient at the time. And then they use their independent medical judgment and knowledge to determine whether or not they can renew an existing prescription that's likely expired for a patient or not. So this is allowed in 38 states. I think I mentioned we've been doing this for 4 years. We're not the only player in the market, but we've been doing it ourselves or with a partner the longest. I think, I mentioned that we use asynchronous technology to deliver this care. And I think, that's one of the big barriers that we've seen. Far too many states have outdated and unnecessary laws and regulations that really prevent the full and widespread adoption of telemedicine, including this type of telemedicine. And so what they require, go ahead.
What does asynchronous mean? And why would that be a problem?
Yeah, so it is really store and forward. So you're collecting the clinical data from the patient. It's not a two-way interaction, and then it's being forwarded to the clinician. What some states require is a two-way interaction, which means we either have to be, some states require audio-visual, like we're doing now. Some states require two-way audio. Some states even require that you have an in-person visit first to establish that patient-provider relationship, and then you could use telemedicine. Generally, that would probably keep you from being able to realize all of the benefits of telemedicine, because you'd only be able to do it with your person that you've met in person for, which isn't how most direct-to-consumer telemedicine products work.
Okay. Well, it seems like and how long ago did this start? People being able to work on, again, 1-800 does suggest it is pre-email.
Yeah, so we about 4 years, I guess, a little over 4 years that we've been doing online vision testing, either through our own technology or working with a partner company to do that. Okay. And believe it or not, there are still states that ban online vision testing altogether, while allowing for all other sorts of telemedicine throughout the spectrum of healthcare to be delivered to patients in those states. Okay.
And Latoya Thomas is with us, the Director of Policy and Government Affairs for Doctors on Demand. Latoya, Doctors on Demand, how do I demand a doctor? And what do you do to get in the way?
No, that's a great question. You demand one of our healthcare providers, which includes a multidisciplinary health team, including board-certified physicians, psychiatrists, as well as psychologists too. And you do so through either our mobile app, which we have on pretty much every mobile device you can think of, running on both an Android and an Apple platform, but also through the website as you're using your personal device, like your PC. And we've been around for around 6 or 7 years now, headquartered in San Francisco. But really the wonderful nature of our virtual practice is that we have been able to practice in 50 states, although hasn't always been that way. It certainly has taken a lot of conversations with the respective licensing boards in all 50 states, including DC, to get them to recognize the use of telehealth as an appropriate way of establishing relationships with patients, and also being able to give our healthcare providers, so many of whom hold more than one license. I'll say, as it relates to COVID, one of the things that I think we were really proud of is that we were ready. There certainly has been kind of a telehealth readiness that I think a number of providers weren't quite prepared for and weren't quite ready to deliver services using this virtual means. But we were available in all 50 states to some degree, and we're able to do this via, for the most part, 24/7. I think one of the key barriers, though, as we were ready and able for patients who were reaching out to us, it was unclear to us as to which states were waiving these out-of-state licensure requirements. I think as Kay so beautifully mentioned, a provider does need a license in order to practice in that particular state where the patient's located. And there have been a number of healthcare professional groups who've created mechanisms to enable cross-state practice. But our physicians hold more than one license. And so when we were ready and prepared to kind of deal with the patient demand from folks reaching out to us in other states, we really wanted to take advantage of some of those out-of-state licensure requirements, but not every state either enabled them. You can think of a state like Illinois that said, sure, we'll do it as long as you have a pre-existing relationship with that patient, which again does not necessarily fit this model when the patient is choosing and exercising their own right to choose who they'd like to see or engage with from a healthcare provider perspective. But then you also saw states that really did respond to it and were really immediate in waiving those out-of-state licensure requirements, like states of Texas and Delaware, even states of Michigan, and even removing some of those administrative burdens so that providers didn't necessarily have to apply and go through an arduous process. As long as they were duly licensed in another state, many of those states were able to just kind of acknowledge and recognize and allow them to see patients during the COVID period.
Now, the federal government has made it easier to get compensated for cross-border medicine as a result of this. What has happened federally, and how much has had to come state by state?
Well, I can tell you that what the federal government has done, and largely through the administration, is they've removed a 20-plus-year-old law, which really prevented patients, especially Medicare patients, from getting access to care based on where they lived. So if you had a patient who lived in an urban area or an area that kind of was on the fringe of rural, but they wanted to choose telehealth, they couldn't have that service covered because they just happened to live in the wrong area, or because they didn't physically drive themselves to a healthcare provider's office to engage in telemedicine. So the administration has removed a 20-year-old regulatory or statutory barrier and temporarily allowing for Medicare beneficiaries to get nationwide access to telehealth, regardless of whether or not they're at home, or if they're at their kid's house, or if they're someplace else within the 50 states in DC. From a Medicaid perspective, they have essentially just kind of given the green light to many of these Medicaid programs, and they've said, look, we want you to use telehealth. We understand the importance and the value of you using telehealth, and it's been great to get their endorsement of this virtual school. They've also kind of given these Medicaid programs the green light to accept out-of-state providers, but again, there's a disconnect between what the administration is encouraging and what the states are actually in a position to do. So while the administration is saying, hey, Illinois, we're giving you the opportunity through a broad waiver to accept these out-of-state providers, unfortunately, Illinois is saying, hey, we're only going to allow you out of state if you have an existing relationship with the patient, which doesn't much that help those who actually need care in an immediate fashion.
Thank you. Nick, are there some types of medicine that lend themselves more easily to telemedicine? Are we likely to see this in certain, I assume we don't do a lot of surgery across state lines through telemedicine. Which areas should people expect to see this open up first?
Yeah, I'm not familiar with any surgery that's being done remotely through telemedicine, but I think when I look at the services and see those out there, I think you can deliver all sorts of services via telemedicine. But I think the ones that have gained the most interest in the last few years are those that are sort of the direct-to-consumer products that provide the ability for a consumer or patient to access on their phone or tablet or their computer access to a physician for a variety of services, from routine follow-up care, acute primary care services, or vision check and renewal services like we offer at 1-800, it really allows them to do all of those things from the convenience of their home or wherever they are. As Latoya mentioned, in this day and age, they could be anywhere in the country and still, as long as they're in a state that allows it, receive services that they might not otherwise be able to have gotten.
Okay. Tay, who or what structures stand in the way of those states that require nurse practitioners to do mother may I with a doctor and his or her clinic or structure that they work in? When you say, wouldn't it be nice if nurse practitioners did things that they've learned to do in university and are competent to do, which everybody agrees, and then people say, oh yeah, but they need to go get a doctor to bless it, or who says let's keep it the old way? What are the structures?
That's a great question. NPs have been providing care for 50 years in the country. And I think when we look at the history of whether it is telehealth or something like a nurse practitioner, it truly is, it's a market disruption. And so we have both some historical, people are used to getting healthcare delivered in a certain way. And so it takes a little while for people to realize that there are more options and explore those options and take benefit. I think the other part, Grover, that we've talked about before is, there are sometimes entrenched market participants that benefit from a market being held a certain way, and that can create some more challenge to overcome. Those challenges definitely are worth overcoming, because both currently now talking about COVID, how do we get more care to more people safely without having them have to come into a healthcare facility if we can provide that care remotely, is also going to be important as we look to recover economically as a country, to ensure that we give people more access to care and provide points of care service that are either more economically friendly or just create more opportunity for states to use players in a different way. One of the things that we've seen in the licensure realm for nurse practitioners and other healthcare providers as well is, when you cut that bureaucratic red tape, those permission slips and some of those hoops that come with it, costs of care go down. When we look at states that require those types of relationships against states that don't, those head-to-head studies show that patient outcomes are high, but we're saving money and costs, we're having decreased readmission, and there's also a bureaucratic cost savings to the states. So whether we're talking about COVID response or long-term healthcare recovery or management, really removing these state level barriers that most of the time are in state statute, so it needs a state statute fix to move forward, are really low-hanging fruit for healthcare modernization.
Okay. For anybody who's joining us now, we've been talking for about 15, 20 minutes about how to step aside, fix, reduce some of the regulatory burdens to get healthcare to Americans, to keep costs down, to make it possible for people all over the country to get the best possible care. And we've been talking to Tay Kopanos, who is with the nurse practitioners, trying to make sure that nurse practitioners can use all of their skills and not necessarily have to get a doctor's permission or say so to make prescriptions and other things. Nick Schilligo, who works with 1-800 Contact, where they can get you contact lenses across state. You can take a test online, and then on some other part of the country, a doctor goes through it and can tell you back, here's the prescription you need, or to re-up the prescription you already have and get that done quickly and inexpensively. And Latoya Thomas with Doctors on Demand, trying to make sure that doctors can practice across state lines. And one of the things that we've worked on at Americans for Tax Reform is on the dental area, trying to get dental therapists approved so people can do mid-level work in dentistry, particularly in rural areas and areas that don't have a lot of dentists downtown. We worked in North Carolina, which had the third highest dental costs and the third fewest dentists. And they had a very serious regulatory system to keep the number of dentists low, the cost high, and the care infrequent and difficult. Unfortunately, that we run into that. Latoya, how many doctors work across state lines now? Is this something 1% do, 20%?
That's a great question. I will tell you that our country right now is dealing with a significant primary care shortage, in addition to dealing with a significant behavioral health shortage in the form of psychiatrists and even child psychiatrists. Each healthcare profession has their own kind of model and approach to enabling cross-state practice. And so you'll see different numbers in terms of healthcare providers leveraging each of those compacts, if you will, or some of those approaches. When it comes to physicians and psychiatrists, they leverage what's called an interstate medical licensure compact, which essentially is a way for you to get your license faster. So you're still required to have a license in each of the states that you intend to practice, but the intention is just to get it to you quicker. So not quite like the driver's license, but I think that there's still maybe half the country, maybe almost 30 states who've entered into this compact, but certainly those states who haven't entered the compact, physicians aren't able to take advantage of it. And then you have the Enhanced Nurse Licensure Compact, which is really a compact for mutual recognition, really looking like a driver's license, where you have nurses in, I think, 30 or 31 states now who have one license to practice. And so that license can be mutually recognized in another state, and that's nurses who are RNs, LVNs, and LPNs. And then you have a SciPact, which is for psychologists. And if you're following along with me, all I'm doing is just making it that much more complicated with all of the different professions and their own approach to enable cross-state practice. But even they themselves have their own approach to enable cross-state practice for their specific profession. All I can say is, at the end of the day, it is quite complicated to license all of these different healthcare professions. But I think at this time, we're probably seeing the most demand from patients for virtual care services, whether they're primary care, whether it's for chronic disease management or behavioral health. The question will be, moving forward, how do we maintain that and make sure that we're not fragmenting the system and just kind of cutting patients off so that they don't get access to the care from the provider that they've previously seen?
One of the things, Grover Norquist Chair, if you're just joining, I run Americans for Tax Reform, and we're discussing how to improve healthcare by reducing some of the regulations at the state and federal level that have built up over the many years that may have made some sense at some point, but perhaps now get in the way of getting healthcare to people who need it at a reasonable cost. If I could ask each of you to do a couple of minutes on what progress has been made in making healthcare more available in the zone that you're focused on because of the virus, and what yet has to be done. Tay, what progress have you seen, and what is yet to be accomplished?
You know, from our work with state and regional disasters, AANP clearly recognized that cross-licensure recognition and those barriers for permission slips would be a problem. So right away, AANP went out and petitioned governors and the National Governors Association to waive those state license requirements, as well as waive those barriers. 5 governors issued executive orders completely waiving those requirements for those permission slips in those states. Those states saw tremendous improvement right away.
What are the 5 good guys?
I don't have them right in front of me, but New York was the first one. Louisiana was also, I think, number 2, and New Jersey number 3. There are some more that are available on the AANP website. If you're looking for model language, Louisiana was pretty straightforward and just straight out simple, saying, hey, we waive these requirements for these collaborative and supervisory requirements. There are other states that waived smaller requirements, such as physician had to be on site with the NP a certain amount of time or do some chart review. Those offered improvements, but not quite the full direction. Other states, of those 28 states that still had barriers, they had more challenges. And we hear from our members that it's creating some inability for them to provide care. I think the most poignant thing that I heard from one of our members was, it is easier for me to go to another state to provide care for patients than it is in my own community. And so I really think calling on governors, even as we start seeing some changes in the curve, we're going to have continued need for primary care, access to care, looking at, in the short term, can we issue more executive orders, waiving these telehealth, cross-licensure, and permission slip barriers? And then long term, how can we change the law to ensure that ongoing care in these areas can persist for patient choice and economic benefit down the road.
Excellent, Tay, thank you. And Nick Schilligo, in the area you've worked in, 1-800 contacts, where people can actually do tests for their eyesight across state lines, but frankly, anywhere in the world, I presume, where a doctor's on the other end there, it can pick it up and go through it and give you a prescription or update a prescription. How much has improved as a result of people focusing on healthcare during the COVID crisis? And what is yet to be done to make this permanent and available for people, all states, all the time?
Yeah, thanks. I mean, I think one of the positives from where we are, there aren't many that have come out of this crisis, is people have recognized that there is a healthcare shortage issue in this country, and that telemedicine is a valuable way of expanding access to care for patients. As I mentioned previously, there are a lot of states that have these audio only or two-way simultaneous interaction requirements in order to deliver this type of care like we are on vision tests, which use store and forward technology. So, for example, Michigan had an audio only requirement, a two-way interactive audio. Arkansas had a two-way interactive audio visual. Those two states, as examples, their governors have put out executive orders eliminating those during this crisis, which is fantastic. The problem is that they're temporary, right? And so it's great to have these temporary allowances for companies to come in and provide that care, but legislatures are still going to need to act in order to allow that in the long term. I know that Illinois, Michigan are doing just that, looking to permanently extend several of the provisions that their governors had put out through executive orders. And I don't know how related it was to what was going on at the time, but actually during this crisis, Maryland enacted a law that removed some burdensome and unnecessary restrictions that will really increase access to healthcare services through telemedicine in the long term. So, it's great to have these temporary things, and I think it'll help people understand how valuable this is. But long term, legislatures need to act to remove these barriers and these unnecessary and burdensome restrictions for the long term.
Thank you very much, Nick Schilligo with 1-800 Contacts. Latoya Thomas with Doctors on Demand. How much have things gotten better during this crisis, and how much more needs to be done to make it possible for doctors to get to where patients are?
Grover, I never thought in my career, and it's over a decade now of me working on telehealth and health IT related policy issues, never thought I'd see the day when the barriers would be lifted for patients who are 65 and older to get access to care wherever they were, for us to remove some of those discriminatory barriers. And so I'm proud to say that my parents now have access to all forms of telehealth where they are, and I feel a relief that they can get access to it, depending on, regardless of what their zip code is. So I'd say that's a really wonderful step forward. We're really hoping, though, and mostly through an act of Congress, that they can work together to make sure that those particular geographic and patient setting restrictions remain lifted, and really allowing for those Medicare patients to choose when, how, and where they'd like to receive care with their trusted healthcare providers. I think it's also been wonderful just to see the patient response once those barriers were lifted, and there's been a large endorsement, promotion, and validation from not just our federal administration, but from some state governors and some departments of health about the use of telehealth, and to see patients respond to that. I think in terms of where we're going next, and some of the barriers that exist that we'd like to see lifted, in addition to the Medicare barrier, one, I think, is just for states to have a plan, a real plan on, in the event of another natural disaster or an emergency, of how they intend to efficiently remove these barriers to allow healthcare providers to provide quality care in their respective states. I mentioned before that there are states like Illinois that have lifted that barrier, but with a condition that you can practice here only if you already have a relationship with the patient here. You also have states like California and Maryland, unfortunately, who lifted that barrier, but he said, but you have to be employed by one of our hospitals or health systems. And that's not a fair market. You know, those are all conditional things that don't allow for practices like ours who have relationships with a number of patients and who want to support those larger systems and allow them to focus on some of the harder hit needs there. But really, it doesn't really allow us to do what we'd like to do in the States, and that's provide mental health and behavioral health services. There's one other thing I think it's worth mentioning, and I think that it's really time for us to rethink how we might be paying for these services. And while there's tons of incentives with the Medicare program and now with Medicaid and even some of the commercial plans to pay for telehealth, I think paying for it from a fee-for-service perspective is just unsustainable. If you're going to pay for every visit, you might as well just kind of leave some of our government programs broke. I think it's time for us to really focus on how we can come up with a different payment model, a more comprehensive payment model with telehealth in mind, and really incentivize providers to have more value-based approaches to providing care using telehealth, including companies like ours, as opposed to just, really just kind of signing off on every visit and not really focusing on quality at all.
Okay. Well, thank you very much, Latoya. We've been joined today. I'm Grover Norquist with Americans for Tax Reform. We work at atr.org. And hope you've enjoyed this presentation, this panel. We've talked for about 30 minutes. This will be up on YouTube and Facebook and through Americans for Tax Reform. Tay Kopanos with the nurse practitioners, Nick Schilligo with 1-800-CONTACTS, and Latoya Thomas with Doctors on Demand. The idea that medicine can work on computers and on phone lines, and that people who've been trained to be nurse practitioners can actually do all the things that they've been trained to do, and that people can cross state lines both on phones and on foot to provide the same services in New Hampshire that they're capable of doing in Massachusetts, seem kind of like obvious steps forward. But Uber probably seemed obvious after somebody started doing it. So it is, I guess, real progress that many states, many folks at the federal, state, and local government have seen that they've been getting in the way of getting medicine and available medicine and doctors' advice and nurse practitioners' advice and work. They didn't mean to, but the laws they passed decades ago did and do get in the way. And so hopefully some of these temporary suspensions of stupid laws can become permanent abolition of stupid laws, because stupid should only last so long. Tay, Nick, Latoya, thank you for joining us. Thank you, everybody who's viewing either now or in the future, for joining us, and keep safe. Take care. Bye-bye.
Thanks, Grover.